For me, it's a pleasure to chair this section because I think this is a very important topic. We didn't discuss a lot about that in this meeting, which is the frail and the elderly patient. And it's very important because you will see that this is an important percentage of the patients we are discussing day by day with sepsis and that have specific considerations that are going to be discussed during this session under the sponsorship of Thermo Fisher. Also, thank you because of your engagement, because we asked you a couple of questions before the meeting, and you participate very actively in that. So I'm going to show you the results of that. Well, as we have the, okay, let's go for the results. Stratification by age is not enough, which is the title of this session. And those are the results of the survey. The first question we asked to you, if you remember, is as older patients are more vulnerable to side effects from antibiotic treatment, do you consider limiting the use of antibiotics in this patient population? The most popular answer was yes, I'm limiting the antibiotics to all patients. And the second was I specifically limit the antibiotic in all patients because we consider that these patients are more vulnerable to the effects. There is not, of course, not a right question. These are the topics this is important information for the discussion we are going to have later on. The second question, how do you think the early recognition of infection in the early patients can be improved? Most popular was by the use of biomarker, such as PCT. The second one, patients with atypical symptoms should be evaluated for possible sepsis and treated aggressively. And the less popular was taking frailty and multimorbidity into account, better clinical assessment. So this is how we are, where we are, and then we are going to keep the discussion with three speakers. Also, we want some interaction from you during the session, so we are going to ask you 1 or 2 questions during each talk. And for that, you have to scan this QR code. You will access to the website, and then for each question, you have a specific QR also for answering and participating in this session. So for this session, as I said, we have 3 speakers. First one is Michael Bauer from Jena. He is going to discuss about the heterogeneity of host immune response in the elderly patient. And then we will keep presenting the rest of the speakers. I think we are going to have the questions at the end because 3 topics are quite complementary. So we are going to do the 3 presentations and then the discussion.
Thank you, Ricard, and welcome, everybody. Actually, I just spoke to Dr. Pilotto, who is a true geriatrician, that we all as intensivists or infectious disease specialists are going to become also geriatricians, and I will show you a couple of data also from our department or research activities later on. So my task is to speak about the heterogeneity of the host immune response when patients turn to become really infected and septic. And this is unheard of in intensive care. It's a rare event. In intensive care, we think sepsis is incredibly frequent, but if you look at it as a public health care perspective, among all patients in England, for instance, 55 million, 2/3 got an antibiotic prescribed by their general practitioner, and only 13,000 died on the ICU. These are data from Mervyn Singer and Manu Shankar in the Lancet. And so overall, we have been trained very well to deal with bacteria because they live on us, in us, and this is this current occurring concept that the human host is a holobiont. So we live with our bacteria, we need our bacteria, and the key question is if this relationship between our microbes or some pathogen that comes from outside and the host turns sour, how do we detect that, and how do we identify those patients in whom the infection is driving organ dysfunction, and how we identify those whom anti-infectives and or immunomodulatory drugs are warranted. So these are the key questions, and we have been faced in critical care with the dilemma that we, due to the fact that this is a highly deadly disease, that it's time critical, that we have been throwing antibiotics at these patients very easily and rapidly. And I guess this is nicely documented in one of these patients, so I take responsibility. It's also happening in our department. You see here also a patient well above 70 years of age who got a very complicated course after cardiopulmonary bypass and operation. And you see that all classes of antibiotics essentially were used in this patient. So are they all really requiring antibiotics? You could ask yourself, how long shall we treat these patients, and are we really supporting the host to recover, or are we treating just the bacteria rather than the patient? So this is nicely demonstrated by this study published a couple of years ago in the British Medical Journal, where admittedly younger women were asked whether they would be willing to avoid antibiotics in urinary tract infections, and they would receive instead ibuprofen instead of an antibiotic for symptom control. And what you see that the resolution of the infection is identical to fosfomycin antibiotic. So we have to rethink perhaps when we use antibiotics, and would such approach be safe in all kinds of patients, and in particular, why do we speak today about the elderly? Is there something specific about the elderly? I guess one key problem is that the typical symptoms of infectious diseases are masked in the elderly, and that unexplained shift in behavior or delirium or abnormalities in psychomotoric behavior, restlessness, lethargy, you name it, or even worsening of congestive heart failure, these all can be symptoms in the elderly that would indicate that underlying infection that does not produce the typical symptoms that we are used to in, for instance, in critical care or in the emergency department are really happening here. And just to also let you know that 2/3 of all patients with sepsis on an ICU are above 65 years of age. So that's why I said we are going all to be geriatricians in the intensive care unit, and those patients that are admitted to the ICU for infection that are geriatric or frail, they have a more than 10-fold increased risk to develop organ dysfunction, in other words, to become septic. And in particular, to just give one example, what is really a concern is that the incidence and the risk to develop AKI, which is a prognosis limiting event with antibiotics, is much higher in the elderly than compared to the younger populations. And accordingly, the risk is much higher to die for these patients on the ICU. So what is so specific about the elderly? And I guess you are all familiar to the term immunosenescence, but this has largely in the past been considered in the context of healthy aging. Inflammation is a feature of the aging host, but these alterations in innate adaptive immunity, also in the inflammatory response, they are key to understand also what happens if the patient develops sepsis or it develops infection in the first place, and why it's so inconclusive. The symptoms are so different compared to the younger patients. So this has profound effects of healthy aging, but it has also dramatic effects on the likelihood to develop sepsis. So sepsis i.e. the development of organ dysfunction when you have an infection, is a risk. The risk factor for this is, as you can see here, an age above, let's say, 50 to 55. So it's a disease of the elderly in both men and women. And more to the point, not only the risk to develop infection and infection that turns sour, but also immunomodulatory strategies are heavily influenced by aging and inflammaging. And you see here, while in RIMAP-CAP, this has been discussed yesterday, there was a signal to improvement when you treated patients with dexamethasone. There's a nice study from Christian Jung looking into the specific subset of the aged patients above 70 years of age, and there's a completely different signal. It seems to be rather dangerous or harmful in the very old population if you liberally use corticosteroids, in this case in COVID-19. So there is clearly a higher risk to develop severe infection, but also immunomodulatory strategies seem to be largely affected by aging. And so what we need is diagnostic tests that would inform us what to do with these patients. And therognostics is a portmanteau form of diagnostic testing employed for selecting targeted therapy. So if I would tell that to my old general practitioner that basing therapy on diagnostics is something new, he probably would ask me whether this is really a radically new concept, because we always did base our therapy, hopefully, on diagnostics. On the other hand side, how do we really titrate, for instance, antibiotics, corticosteroids in these patients? That's when theragnostics comes into play. So how can we, based on biomarkers, define the point where we start or stop antibiotics or immunomodulatory strategies? So biomarkers are signs that you can objectively measure, so not like opposed self-reported symptoms that are highly variable, and it's not restricted to peptides and RNAs. It can also be like the need for oxygen, as we learned in COVID-19. So I would like to show you a couple of data on a large observational trial that we did with almost 1,500 all-comers to the emergency department with suspected infection that were Q-SOFA positive, and we wanted to know who is going to develop sepsis and septic shock within 96 hours after admission. And so we looked at the performance of Q-SOFA alone or along with PCT with a cutoff of 0.25 or 0.5. And what you can see here is that the specificity and the sensitivity can largely be improved and optimized, and you can rule in these patients, in these all-comers to the ICU, whether they are going to develop a decompensated inflammatory response and development of organ dysfunction. So we asked in this study also whether additional markers that are indicative of organ dysfunction, such as adrenomedulin or dipeptidyl peptidase or proencaphalin, I can't go into detail into these biomarkers, but it seems that currently PCT is the best and the only required to really identify those patients at risk. And so the net reclassification improvement was dramatic. So PCT as a biomarker in all comers that present some symptoms of infection is largely improved when you add PCT as the biomarker. And I already said that we are going to be all geriatricians. We looked at the subgroup, and these were 10% almost of the patients, 138 patients that were above 85 years of age. And you see that the same holds true when you add to the Q-SOFA PCT as a biomarker, you get substantial improved performance of the marker, and just the clinical symptoms only are indicative in 21% of the patients, and you go to above 80 or around 80% detection when you do that. And I guess what we can really learn from the studies that have been conducted so far in sepsis and in lower respiratory tract infections is that we can substantially shorten the exposure to antibiotics of these patients. And this is particularly nicely shown here for the lower respiratory tract infections. So you can just use PCT to stop antibiotics. You can shorten the exposure to antibiotics by such an approach. So this has already made its way into the guidelines. So there are quite a number of RCTs that have tested it, and there is a patient-centered benefit if you use such an algorithm where you incorporate PCT into antibiotic stewardship programs to cut down on the exposure to antibiotics. So let's sum it up like that. Age is the risk factor for sepsis, and more than 10-fold increased risk for the elderly to develop organ dysfunction is really something serious to consider. And this would argue really to use really antibiotics early and liberally, but on the other hand side, as the off-target effects of antibiotics, such as development of Clostridium difficile or acute kidney injury associated with antibiotics, is another problem in these patient populations. Restrictive antibiotics should be warranted. And I guess this dilemma can only be solved by incorporation of both aspects in a PCT-guided antibiotic stewardship program. And I guess this is meant to set the scene for this discussion that we are going to have in this session. And thereby I'm gladly taking some questions. Yeah.
Thank you, Michael. We will have a debate at the end. So it's my pleasure to invite to the podium Professor Alberto Pilotto. He's the director of the Department of Geriatric Care, Orthogeriatrics and Rehabilitation in Genova, Italy. I think his point of view is going to be very important for us because he will assess the topic of how we systematically assess frailty in our patients with sepsis, but I mean, more general approach also. Thank you.
Thank you. Thank you for invitation in this fantastic contest of the historical university in this important congress. My talk will be on the systematic assessment of frailty from a geriatric point of view. And I will start from the concept of aging. Aging is a biological process characterized by a great heterogeneity. And this great heterogeneity, all of us know very fit people, old people, very fit, robust, and all of us know old people, frail, vulnerable, disabled, with a lot of chronic disease. All this heterogeneity depends from the health status, of course, mainly comorbidity and polypharmacy, but also by functional, cognitive, and mood, mobility, nutrition, and psychosocial and economic aspects. For this reason, geriatric medicine developed the comprehensive geriatric assessment and management to explore and define the clinical profile, the pathological risk, and the residual skill in order to manage a personalized care plan. This comprehensive geriatric assessment and management approach, in the almost 40 years of a lot of randomized clinical trials, demonstrate that in different settings, inside and outside from the hospital, at population level, for example, reduce very strong outcomes, reduce mortality, institutionalization, readmission, and also in specific clinical conditions, orthopedics, surgery, oncology, reduce, for example, postoperative complications and may influence the therapy in oncology setting. So, how, from an operative point of view, we can determine and define frailty? This very important consensus conference project grouped 150 expert geriatricians and non-geriatricians, social workers, basic scientists, healthy professionals. And the result is the definition. Frailty is a clinical syndrome characterized by the decreased reserve and diminished resistance to stressors, multidimensional, involving different components. And important for diagnosis are the physical performance tests, mobility, cognitive status, psychosocial, nutritional status, and of course, the diseases. The multimorbidity, disability, the geriatric syndromes and functional status, of course, are important in the infections. And literature report many data on these aspects. And during COVID pandemic, we observe just at the beginning, you can say at the March of 2020 year, that the frailty was very relevant in driving the trajectory of the SARS-CoV-2 disease beyond chronological age and also beyond the multimorbidity. European Medicine Agency recognized in this important reflection paper on frailty that a complete evaluation of frailty to support its management requires a multidimensional, interdisciplinary, comprehensive geriatric assessment, which is the gold standard in clinical practice. And few lines in the same documents, in few lines, they report that the MPI, multidimensional prognostic index, is able to extract information from the CZA to categorize frailty in subgroups with excellent prognostic value. That it means over 90%. Unfortunately, among the most commonly used frailty instrument that you can see reported in this excellent paper published in Lancet, only 3 instruments were based on a comprehensive geriatric assessment. And among these, only the multidimensional prognostic index was validated in the primary care setting, hospital setting, and also in long-term care facilities. Many articles demonstrate independently that the MPI has a clinimetric properties in terms of accuracy, calibration, generalizability, comparison with other indices, sensitivity to variation during time, reliability, feasibility, and now I will take some, I would like to show you 2 or 3 experiences about the usefulness of this approach in clinical decision making. For example, the MPI predict the outcome of pneumonia in hospitalized geriatric patient, and the accuracy was significantly higher compared to organ-specific parameter as the pneumonia severity index. Other experience has been reported in patients with acute respiratory failure. And for example, the multidimensional approach as reported by the MPI was the most effective predictor in predicting mortality and success of failure of the non-invasive ventilation. And it has been possible also to identify a cutoff value over, for example, in this population of over 0.84. During COVID pandemia period, a special interest group of the Comprehensive Geriatric Assessment of the UGMS, the European Geriatric Medicine Society, demonstrate in a multi-dimensional, in a multi-center study that the MPI was excellent in predicting the trajectories of the infection, demonstrating also a specific possibility to identify the different length of hospital stay, and demonstrating that for the increase in 0.11 of MPI increased the risk of mortality of 41%. So the conclusion is that these findings may be of importance for introducing prognostic factors derived from the CZA in daily clinical practice in hospital, and not only age that our study again has indicated as poor prognostic factors. Indeed, from the same study group in this paper, including more than 500 older patients, it has been possible to demonstrate that including the MPI in a prognostic algorithm that include age, sex, hemogas analysis parameters, we have a significantly improvement, and in terms of NRI, net reclassification improvement, it has been possible to observe that the MPI increased 0.27%. That it means that 1 patient out of 4 patients is better classified in terms of the trajectories of the disease, of the infection, compare patients without the comprehensive approach. So again, the conclusion of this paper were that performing a comprehensive geriatric assessment may help the physician to refine patient selection for mechanical ventilation and to take into consideration not just clinical, radiological, or arterial blood gas parameters. Of course, MPI may improve in terms of accuracy. For example, including in the model a biomarkers such as the procalcitonin. In this exploratory study, a significant increase in predicting 1 month mortality in older patients with pneumonia was observed. And very interesting is to compare what it happens when I did a multidimensional approach with a CZR, MPI-based. This study is from Denmark, with a very label frame, a clinical frailty scale. And the authors' conclusions are that the bedside MPI is valuable as a systematic application of CZA. MPI can be recommended to detangle the complex physical and mental health needs among elderly, and of course for the discharge planning of the geriatric, from the geriatric wards. And my conclusion are that this editorial, this is from a cardiologist group from Canada. They commenting on circulation a paper on the use of the MPI, multidimensional prognostic index, in patients who undergo a transcatheter correction of the aortic valve. Quoted a famous statement of Albert Einstein: everything should be made as simple as possible, but not simpler than it is. And in this editorial, the authors endorse the multidimensional representation of frailty according to its impaired domain, because this allows clinicians to pinpoint areas in need of targeted defrailing intervention, or to prevent or to treat prevention to frailty. They endorse the continuous representation of frailty because this allows clinicians to gain insights into the patient's status rather than oversimplifying their status as frail or not frail. All else being equal, octogenarians with low level of frailty have completely different prognostic expectation. Please remember the first slide. The key takeaway is that positive patient-centered outcomes are determined by much more than the technical success of the procedures. They are talking about the cardiological procedures, by the geriatric profile of the patient. This seems to me very important from a geriatric point of view. And the first step forward is to assess frailty using objective multidimensional tools, and to discourage the binary frail, non-frail label in favor of a spectrum of frailty, severity, and treatable domains. Where I can find out the MPI tools, Multiplat Age.it is a project, a long project by the Italian Minister of Health, and it's possible for free to download the different versions of the MPI, the hospital version, the ambulatory version, the tele-MPI for telemedicine, the brief MPI for emergency department and non-geriatrics wards, and the digital selfie or selfie MPI for the self-administered assessment of frailty. Thank you for your attention.
Alberto, I'm sure there are a lot of questions from the audience for you. I'm going to wait a little bit until we finish, and then we are going to have the discussion. I don't know if you have questions in your QR. No? Okay. So we can proceed with the QR. At least we have one question. So while you are voting, I'm going to explain you an anecdote. I was invited by the European Society of Intensive Care during the first wave of COVID to talk about how we are managing that. And in that times, many of my colleagues are in the room. We have scaled the ICU from 50 beds to 200 beds. And we are close to the end of ventilators, beds, everything. And during my conference in this webinar of the European Society of Intensive Care, they asked me, Mauricio asked me, which is going to be the next step? And I answered, I really was close to be desperate. I answered, maybe we have to start to reduce the admission of patients above 75. This is the most complicated statement I made in my life. Next day, I received like 15 calls from media around Europe asking me how I'm going to discriminate people just because age in our ICU. So I have to correct this statement. I have to talk with all media and saying that it was my mistake, that we are taking care also of frailty with the clinical frailty scale. But this is just an example, but also here in Spain, the general prosecutor also contacted us in the Spanish Society of Intensive Care, saying that if we are discriminating by age, he's going to consider the same that discriminating by gender or race or any other thing. And this is not acceptable. And we said, no, we are not doing that. Our protocol is not saying that. We are taking into account frailty. But some organizations also asked the general prosecutor to be sure that age is not taken account as a single value for treating patients or admitting patients in the ICU or for treatment decisions, any treatment decisions. Which symptoms are indicative of an incipient infection? Of course, in the setting of the elderly patient, and you can see here a lot of variability. Yeah, this is your first question, okay? So variability, maybe we can say from that. All right, okay. Second question, I don't know if we can make it. Which statement is wrong? Antibiotics should be given during the immunosenescence liberally in suspected infection. Antibiotic-associated off-target effects are more frequent in the elderly. PCT can help to reduce antibiotic exposure in severe bacterial infection. Immunosenescence triggers inflamming as well as defects in innate and adaptive immunity, and age is the predominant risk factor for development of sepsis. Have to wait. It's taking a little bit long. Okay. So you consider, half of you consider that it's wrong that antibiotics should be given due to immunosenescence liberally in suspected infection. Good. So we can proceed with the presentation. So my topic is about uncertainty. Uncertainty is in those patients. So it's true that there is not a lot of information in this specific subgroup of patients. There is information about antimicrobial stewardship, and the same protocols that apply for the general population apply for all patients, but not for the levels of PCT or other biomarkers in the moment of the infection. So the trend and the algorithms are valid, but not a lot in the setting of diagnosis. To insist, this data is a little bit old, it's coming from Australia and New Zealand, showing trend in mortality. There is a reduction in mortality across the years, also in the elderly population and in the comorbid group, but the reduction in mortality is less than in other subgroups, and this is the biggest subgroup. And the most important thing is that what changed in the recent years is a lot of patients are discharged to long-term facilities. So this is in relation with the frailty. I think this is important. This is our data set here in Spain. We collected this several years ago, and there is a specific analysis about the elderly patients that by the group you see listed here. Again, this is a very important subgroup, 65% of the patients. Hospital mortality close to 50% in ICU patients admitted with sepsis above 65 years. And of course, the group above 80 is mortality is higher, but it's not age is the only factor associated with mortality. And I want to stress the sepsis resuscitation bundle. We don't have frailty in this analysis. We don't have comorbidities. Well, it was several years ago. We didn't assess that in that moment. But I want to stress that sepsis resuscitation bundle, specifically in the older patients, is a protective factor. So early treatment is also very important in those patients. So identification of those elderly patients with a risk of deterioration is key, because this is the starting point for the sepsis pathway, for the starting or all the 1 hour bundle. And of course, this hour bundle should be taken with caution, because the three most important elements of the bundle, those patients we discussed, Michael has discussed about the effect of broad spectrum antibiotics, also the potential effect of 30 ml per kilo of crystalloids in a patient with probably cardiac dysfunction, and also the risk of early vasopressors in terms of arrhythmia in patients with a potential cardiopathy. So everything is, we need to identify the patients, we need to act rapidly, but the tools we have more risk than the others, and this has been alluded before about the alteration in efficacy, but also in safety of the antibiotics in elderly patients. So it's important. So I have the suspicion of sepsis in a patient, elderly or not, and I want the biomarker for, in this situation of uncertainty, rule in or rule out infection, especially in the elderly. Because in the elderly, if the patient have sepsis and we delay the treatment, probably the patient has only one option. Sometimes we don't escalate in very old patients the treatment, so it's important to rule in, but also it's important to rule out to avoid the effects of rapid fluid resuscitation, antibiotics, etc. So reduce the uncertainty, it's important. For us, when we are evaluating the biomarkers for this setting, for uncertainty at the moment of the diagnostics, usually we do it outside of the ICU. So we are not doing at ICU admission or during ICU admission, because we think that at ICU admission we don't have uncertainty. The patient is severe and it's already in the ICU. So we like it to do it when we visit for first time the patient, many times outside the ICU. We said that sepsis code activation. And PCT is the biomarker that is selecting better those patients with infection. With which cutoff? There is a lot of heterogeneity again in that. In this meta-analysis, you see different cutoff, and the median cutoff, 1.1, the median, but many studies select different other cutoff for the best value of procalcitonin for saying this patient have an infection or not. So with this data means that we can reduce the uncertainty, for example, from 20% to 60% to 50% for ruling in, or 7% for ruling out. So it's not the magic bullet, but it's helping, it's reducing the uncertainty, and it's the best tool we have. with my colleagues and others, we try to write how we can build an algorithm for elderly patients based on the information we have. And we build this algorithm. This is still not published, it's submitted, and we still are in the publication process, but we set up for mild moderate illness a cutoff of 0.25 for PCT. If the patient is below this cutoff, then we can look for alternative diagnosis, look for virus, wait for the antibiotics, and recheck. Levels above 0.25, then antibiotics, and we recheck and we look to the clinical response. If the patient is in a severe condition, the cutoff is 0.5, and then if you have moderate certainty that this is a bacterial infection and the patient is in a severe condition, we consider that the patient should receive antibiotic, but if the levels are below 0.5, we have to look for alternative diagnosis, virus, etc. So this is our proposal. Also, for identification of those patients, we have talked a lot about rapid diagnostic tests. I think can be helpful. So in fact, if the patient have a bacterial or virus identification, that can help. Which role have the scores? This is the old SIRS criteria that have been used for many times, 40 years now, 30 years now, of the SIRS criteria. The problem, as Jean-Louis and others express, is that most of the patients in the ICU have SIRS criteria. 87% of the patients have SIRS criteria with infection and without infection. So we have a problem of specificity here, clearly a problem of specificity in patients in the ICU. That's why QSOFA came in the recent years, trying to increase the specificity of the scores. QSOFA that take into account the potential alteration in mental status and tachypnea. And okay, the specificity increased, 84%, but there is an important decrease in sensitivity. So in terms for research, for example, or trials, this is very interesting because all the patients with this criteria are going to have sepsis or risk of deterioration at least. But for clinicians that look patients at the bedside, if you are going to miss 50% of the patients, this is not useful. So that's why they're still looking for alternative to QSOFA. And some of the other scores like NEWS, MUSE show better sensitivity than the QSOFA. Here you can see a comparison of the different scores, and NEWS is the one who performs better. And in fact, the Foreign Sepsis Campaign guidelines said in the last iteration that they suggest against the use of QSOFA and they prefer other scores for looking for patients with sepsis or with risk of deterioration. So how we can increase the sensitivity of QSOFA? Maybe using biomarkers. We wrote that with Tony Artigas and Tony Torres a year ago, saying that maybe proadrenomedulin is the biomarker that can help in sepsis in that sense. So again, we go to the sepsis co-activation and we check if proadrenomedulin is detecting 28 days mortality or 90 days mortality. ProADM was the best one, but again, it's not impressive area under the curve, but in fact it performs better than all the other biomarkers. This is a recent meta-analysis we did with a group here in Spain, still unpublished, and you can see that the different biomarkers at sepsis identification are not able to identify those patients who are going to die. Only high levels of procalcitonin, and in fact in our practice it's like that. So we receive an SMS when we are on call with the procalcitonin levels of all patients with sepsis co-activation around the hospital, and if the levels are very high, the team is at least looking to this patient, but not for the rest, not a good correlation with mortality. So combinations, as you did, Michael, combinations of QSOFA with biomarkers has been tested. With lactate, the improvement in sensitivity is quite interesting, 65%, keeping a good specificity, 81%. With PCT, I cannot find your numbers, so there are some publications saying that you can increase sensitivity, but with surprise in specificity, with a decrease in specificity. And the best ones are for ProADM. Combination of ProADM with QSOFA increased sensitivity up to close to 70%, keeping a high a specificity of 97%. So I think this is an interesting approach. Adapting QSOFA to the geriatric population has been done, specifically for the definition of alteration in mental status, which is quite vague. And improving that, taking on delirium, the sensitivity increased 92%, but again, specificity goes down. So it's always a trade-off between sensitivity and specificity. The last topic I want to mention is about the use of data. So this is a concept, how we can be better intensivists, training, knowledge, machines, but also the use of data. So, Derek Angus alluded to that yesterday. It's about the uses of electronic alerts for detecting those patients, based on new algorithms or based in these scores. And some of them, at least 3, show good sensitivity and specificity, and at least 2 of them show some clinical benefit, some value. So faster administration of antibiotics, faster determination of lactate, faster ICU admission, shorter length of stay. So this is because of the feasibility of these electronic alerts. This is a topic for the next years because it needs a lot of integration in the hospital with the different streams of information to have these electronic alerts in place. But probably it's going to be superior to the other scores or tools we have. And this is my last slide. This is a review we written a year ago with Alex Soriano, has been here, and others, saying, okay, we have these new antibiotics, very potent antibiotics, where we should use that if the patient have at least some risk of multi-drug resistance. And we said, of course, the patient in septic shock, if they have risk of multi-drug resistance, patients in sepsis, but there are other subgroup of patients that they are not in organ dysfunction, that probably if they have a multi-drug resistance and we do not cover it, the patient will deteriorate very fast. And also maybe we don't provide additional care because the patient is frail and is old and we are not going to scale for ECMO for sure or for invasive mechanical ventilation. And we agreed that comorbidities and high levels of PCT can be considered also as factors in this specific population that can be a trigger for this type of antibiotics. Together with Thermo Fisher, we tried to put together all our sepsis pathway in the hospital, taking into account the application of biomarkers, etc. And this is accessible. And if it's useful for you, through Thermo Fisher, you can get it. Thank you for the attention. So we have some minutes for debate. Any question? Yeah, there is some question in the second row, please.
Thank you very much. Thank you to excellent reviews. I have a question for Michael. Some biomarkers we know quite well since a long time ago, how they work and they change during the age and what changed with aging. I'm not aware of any work assessing how PCT change with the age. Are you aware of any data on that, if it is change in population-based and also in the ICU?
Actually, we have done this analysis on this data set, and I showed the sensitivity specificity for the subgroup of 85 plus. And when you plot on the x-axis age and on the y-axis the PCT for different classes, the SOFA score on the x-axis and the PCT on the y-axis, and you have 3 defined classes based on the geriatric cutoffs for age. What you see is that with the higher age, in particular above 85, there is a shift of the PCT values compared to the younger patients, but the kinetics are very similar. So I guess it's useful. The cutoffs seem to work for the diagnostics and also for the stewardship programs, but the older you are, the higher your likelihood to have severe organ dysfunction and the higher the PCT level, because the PCT level correlates very well with the SOFA score as a surrogate for the severity of organ dysfunction. Whether this is related to later diagnostics in the older patients or whether that is related to the fact that older patients develop more severe organ dysfunction, I can't answer with a correlation.
Maybe some factors that affect the levels of PCT, like renal function, that can play also a role.
Yeah.
Thank you very much for the lectures. I think elderly is really a burning issue in our society, and I have two general comments. One, we should get rid of the thresholds of age. This is something that, Dr. Pinotto, you have to explore some other issues, that the number. We have to get rid of the thresholds, because you can have a patient with 60, but is very old, in fact, is very immunosuppressed, and another one with 80 that is not immunosuppressed. Yeah, and then the second general comment. So the medicine, the science, and everything are inventing things, are making new treatments to prolong the life. No? But on the other hand, there is the general misperception that all this population, well, they have to die because they are old. Something, and I was one of that called you that day in that webinar. No, I'm joking, no?
I know. So no, you make a very good point, because in fact, during the last wave of COVID, the only patients that need ICU admissions are the frail patients. And there are a lot of frail patients. You notice that the amount of patients with kidney transplantation, the amount of patients with comorbidities, the amount of patients that survive after cancer but they still need treatment, or hematology, et cetera, in our population, specifically in these cities in Europe that the population is getting old and old, it's an important amount. So it's not just a problem of a specific subgroup, it's now a common social problem, because an important percentage of the population are part of this. Go, please.
Just a brief comment from the BIP group from the European Society of Intensive Care Medicine, published 2 papers with more than 5,000 patients, all patients older than 75 years old, with sepsis, compare with the control group of younger patients with the same organ failure with sepsis, and that we were able to demonstrate that sepsis is not the cause of the major reason to die these patients. So sepsis is not contributing as in the independent factor for the mortality in these patients. Is you have a group control. And so I'm saying this because then what is the role of the biomarkers there? Because patients that we found is that frailty was the key independent factor to predict the mortality in these patients. So if it's not sepsis, is frailty, that probably because they have comorbidities, etc., etc. So how we need to focus the biomarkers to identify or to improve the prognosis of these patients?
Actually, this is a tough question, but
you know these 2 papers, no?
Yeah. No, actually, from my point of view, we should really look at the evidence that is available, what can the biomarker add, and what is a patient-centered benefit. There is solid evidence for PCT that the added value is you reduce the exposure dramatically for antibiotics. I showed the data for lower respiratory tract infection in particular, where you can reduce it by 30–40%, and this is considered in particular in the frail and in the geriatric patient, a patient-centered benefit, because when you have a prolonged period of antibiotics, this will lead to disruption of the microbiome, dysbiosis, acute kidney injury, and so on. So I guess the best validated patient-centered benefit of biomarkers in this setting, although I can't comment why frailty is such a high risk factor for mortality in these patients, but what we can definitely say as a patient-centered benefit, we can reduce exposure to antibiotics by the use of, in particular, PCT. I don't know whether Dr. Pilotto wants to comment on frailty as a risk factor for mortality beyond the development of organ dysfunction.
In the last number of the journal Geroscience, a little group of geriatricians, including Lawrence Rubinstein, who described for the first time in the 1984 the first randomized clinical trial on comprehensive geriatric assessment, comment on the usefulness on the comprehensive geriatric assessment in the as a prognostic tool, and is reported the role of the crucial role of the multidimensional approach in prognosis, as I showed before, but also in identify the combination of the phenotypic frailty and the biologic frailty. That it means that most probably we need to start with a new road, a new way of thinking that include the role of biomarkers, biological age, and the phenotypic age, chronological age, and all these parameters need to be included in a sort of algorithm to better obtain sensitivity and specificity predictive in order to do a better and more appropriate clinical decisions. In my opinion, we are at the start of this road, and this road cannot be done only by geriatrician, only by intensivists, only by experts in infectious disease. We need to join together our different expertise. I think so.
I want to ask you a short question. We are out of time, but I want to have you, it's very important to have you here and to hear your advice on that. Two situations, emergency situation, bedside, patient with sepsis, or any clinical deterioration, how we have to evaluate make the geriatric assessment or the frailty assessment of the patient in this specific situation, and how can it help for treatment and prognostication. And then in a more quiet situation, the patient is already in the ICU, and then you have to take a decision about continue or not continue or whatever. How we evaluate this factor?
I think that it should be correct to adopt a screening tool before, in order to have an idea of the real risk of patient. When you have the screening tool that alert you a warning about a negative trajectories of the patient's disease, my feeling is that should be conclude or enlarge the evaluation and with a complete comprehensive assessment. This is the concept of an interaction between different health professionals. I don't think that we don't have any other possibility to improve our assistance to older people.
I think it's a good conclusion. I think it's a good conclusion of this session. Thank you very much.
Thank you.